Um, okay, we're live. I'm ready. Hello, my name is Daniel Steck. I'm from Frontier Nursing University and HealthNet in Indianapolis. And today we're looking at improving effective extragenital sexually transmitted infection testing in an urban federally qualified health center. The aim of the project is to increase effective care by screening and testing those at risk for extragenital gonorrheal and chlamydial infections to 60% by March 8th of 2019. Gonorrhea and chlamydia continue to be a public health concern and are on the rise for the fourth year in a row, with over 2 million cases in 2017. The majority of these infections are found via urogenital testing, but research shows a large reservoir of extragenital infections in men who have sex with men, women who have sex with men, and men who have sex with women, with greater than 75% of infections in MSM and greater than 15% in WSM being missed if only urogenital testing is done. These and other sexually transmitted infections cost the United States around $16 billion annually. In order to effectively reduce the number of gonorrhea and chlamydia infections and potential complications, patients must be tested according to risk and behaviors. 20 charts were audited from January of 2018 through October 2018 from the Titleton Clinic of HealthNet. This clinic currently uses an extensive health history form that includes a plethora of sexual health questions. However, despite the use of this tool and inquiring about oral and anal sex, only 3 out of 10 or 30% and 1 out of 3, 33% of those who stated that they had oral and anal sex respectively were tested for gonorrhea and chlamydia at the appropriate anatomical sites. According to research, healthcare staff engage in a more positive way when more comfortable with sexual topics and when focusing on behaviors rather than identities. But the team involved with this project had a baseline comfort engagement score of 1%. While 13 out of 14 of surveyed patients want to take an active role in their care, 11% feel they do not have all the knowledge and tools to make the best decisions for their care. These improvements will change the team by increasing the mutual support among team members and improve engagement amongst each other and with their patients. A shared decision-making tool will be available to interact with patients in a way that will increase effective care and allow patients to take a more active role in their care. The organization will benefit by having a more robust STI program that can be scaled and expanded to the other clinics within the system. And by identifying infections that might have otherwise continued undetected, the community will benefit by decreased subsequent infections and a reduction in overall morbidity and healthcare costs. Here are the various tests of change we're looking at throughout the project with their process and outcome measures. You can see the operational definition of the before mentioned aim, as well as the balancing measure of urogenital STI, gonorrhea, and chlamydia testing, since we're doing a good job of that so far. Here are the stakeholders involved in this project that cover a variety of positions, including patients, the direct Title X staff, the RN team lead for the clinic educator, the lab director, and both the deputy chief operating officer and chief medical officer. Here we take a look at the basics of the 4 core interventions that we are planning. We're looking at enhancing the existing weekly meetings to be more interactive and focused on QI, using a shared decision-making tool to help patients take a more active role in their care after being educated on STI risks and options, then screening those who are found at risk based on their sexual behaviors, and treating those who test positive, and tracking the right care bundle and counseling and follow-up. While we hope that all these interventions will take place without any barriers, we must anticipate possible issues and roadblocks along the way. To mitigate these barriers for the team, we will have frequent touch points with role play, guest speakers, and literature reviews, and consider changing meeting time to accommodate more team members. For the patients, we can increase visibility and normalcy of topics in clinic by hanging posters with sexual health topics in the lobby, exam rooms, and restroom, and with wearables for the staff to wear with sexual health topics on them. The process, we will have tools translated into Spanish and give tools to patients before the provider arrives. And we also will look at creating a digital master version of the case management log so that it doesn't get lost. Here are my references, and I welcome any questions.
Nicely done, 418.
Perfect. So I can talk a little slower.
I was going to say, you talked just fine, didn't really seem like you're talking too fast. Covered everything appropriately.
Okay, good. Anything that you think might have been, there's a couple points I just realized as I was going through them, I need to change a couple things, but anything that, yeah, you felt was like left out?
I don't think so.
Okay. Did it make sense?
It did.
Okay.
Yeah, no, it was good. It was a really good presentation.
Because I feel like she doesn't understand what I'm doing.
I know.
I had that whole conversation with her because she sent me a comment and I was like, whoa, 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 whoa. Hold on. Can we
Right.
make sure we're on the same page?
Yeah.
And then afterwards she was like, oh, okay. And then she made a comment because I kept getting points off for my operational definitions for like for my aim and my balancing. I kept putting the statements and not the operational definition because that's what the examples all showed anyway.
Yeah.
And now the new one wants both the statement and the operational definition. So I'm glad at least
I have both in my table in my worksheet.
Yeah.
Like I have my
I
operational definition above, and then I have my aim statement down below.
Yeah. So
That's the one reason
so then she said, like, I need my operational definition. So I sent it to her. I was like, hey, just like checking, like, this is what you're looking for here. She was like, on the balancing one, she was like, your aim's good, but your balancing, you know, you need to be looking at something that's going to go awry if you do yours. And I was like, yeah, that's why we chose urogenital, because we're doing extra. She's like, oh, I read that as extragenital. Sorry, my bad. And I was like, because I was like, oh, I've been working trying to get this for you.
Yeah.
Anyway, okay.
All right.
So yeah, try. I don't know if you care, but I mean, you could try just doing, instead of doing share whole screen, just do application window, and then select your presentation. Yeah.
Okay. All right. All right, here we go. Good evening, everybody. My name is Bethany Odero, and I am a non-practicing women's health nurse practitioner, a student at Frontier Nursing University, and I work.
Sorry, I'm gonna stop you because it's showing like still all your like the slides and the notes and all that.
See, that's what happens when I do it the one way. So I'm.
Okay.
I don't.
Well, mine was the whole screen, right?
I can just do the whole screen.
Interesting. Okay.
I present to everyone. Oh, did I just?
Just close it.
I did. I was like, where did it go? Okay. Slideshow from the beginning.
Okay.
How's that?
Okay.
Is that better?
Yep.
Okay. All right. Good evening, everyone. My name is Bethany Odero, and I'm a non-practicing women's health nurse practitioner at Frontier Nursing University, and I work at University Hospital. The title of my project is Effective Screening and Treatment for Perioperative Hypothermic Patients at Indiana University Health University Hospital. The aim of my project is to screen and treat 80% of our perioperative patients for hypothermia over the next 90 days. 37% of our patients experience hypothermia during the perioperative experience, and of those patients, 85% of them experience a delay in PACU. Patients who maintain a hypothermic state are at increased risk for surgical complication, neurological deficits, and longer lengths of stay in both the PACU and in the hospital. Most of our patients are staying in PACU for an additional 2 hours, and over the course of the year, these patients spend an extra $700,000. So some of the reasons for the effort is that our current daily huddle rate is at 33% between the 3 departments. Our current patient satisfaction score is 76%. 30% of our patients have a temperature below 36 degrees Celsius, with 0 interventions currently occurring in our pre-op area. 50% of our patients have a temperature below 36 degrees, with only 30% of those patients receiving interventions in the OR. 30% of patients have a temp below 36 in our PACU. In the PACU, nurses really only care about temperatures below 35.5. So we're missing treatment from 35.5 to 36 degrees Celsius. Patients are being treated for hypothermia at a rate of 32% of the time with an intervention other than a bear hugger. Some expected outcomes I hope to see in this project is that patients are normothermic throughout the entire surgical experience. Patient comfort measures are being met in both the pre-op, in the OR, as well as in the PACU. We want to increase our patient satisfaction scores by meeting their comfort measures. We want to decrease patient delays in the PACU and in the hospital, and we would like to decrease our surgical complication rate as well as reduce the patient and hospital costs. So here are the process and outcome measurements for our team huddles, my comfort measure and engagement tool, the hypothermia screening tool, the right care or treatment bundle package with using a CML log. The aim is based on the average of the screening and right treatment bundle, and my balancing measure is that right now we are currently using and documenting bear huggers 100% of the time, so I would like for that to not decrease below 90% over the next 90 days. Key stakeholders are managers in all three of the areas, and PACU, our clinical director for the perioperative services, our clinical director for quality improvement in our anesthesia department, our perioperative nursing staff, and as well as our ancillary staff, and of course our perioperative patients and their family members. Some initial changes that I would like to initiate on that very first day is introducing team huddles in all three departments, initializing and implementing comfort measures engagement tool in our pre-op area, as well as initializing the perioperative hypothermia screening tool in the pre-op, and continuing that screening tool in the OR as well as in the PACU, as well as implementing the right treatment bundle, case management log, and making sure those patients are receiving interventions at any point in time. Some barriers that I kind of expect to see is that failure to participate in the huddle can impair communication with each other. So just giving that education as to why huddles are important. And another reason it would be for a lack of time. So sticking to our agenda will be crucial. So for the patient engagement tool, one barrier would be low health literacy. So making sure it's a tool that everybody can understand. Some patients are reluctant to be involved in their healthcare choices because they feel like medical professionals make the best decision and that's who they would rather listen to, as well as there could be potentially a language barrier where English is a second language or isn't spoken at all. For the screening tool, barriers could be a lack of time to utilize the tool, some educating the nurses how important this tool is, as well as lack of understanding what the tool is actually asking. So making sure that we do an educational session with our pre-op nurses so that they understand what the tool is used for. And then for the case management log, some of the barriers would be lack of understanding as to what patient goes into the log, as well as lack of time to input that data in the log. And here are my references. All right, that was 449.
Okay. I have made a note.
Yeah.
I'll just come up there though, because like, show you a natural thing.